Welcome back, everyone. On with our next session, which is on how can peer support change healthcare. Now we have a truly wonderful panel. We've got Adele Framer, Karen Hoffman, and Sarah Tilley with us. And the way we're going to run this is that they're going to first of all introduce themselves and say a bit about their work. And then we're going to have a bit of a discussion amongst themselves around a couple of questions that they've prepared that they think are important. But we're going to leave close to half an hour, maybe 25 minutes for your questions. They're very keen to take your questions to make sure what they have to say is addressing where you're at, which is sort of the nature of peer support, I guess. So please put your questions in the Q&A. I'll try to get to as many of them as we possibly can. So we'll start with Adele Framer. If you'd like to introduce yourself, Adele, welcome.
Thank you, John. My name is Adele Framer, and I run a website called survivingantidepressants.org, which was founded in 2011, and we help people taper all kinds of psychiatric drugs. And we also provide peer support for people who have protracted withdrawal syndrome after they've gone off the drugs. We currently have about 18,000 members. In over all this time, we've collected about 7,000 patient narratives about tapering and withdrawal syndrome. And the site has been the subject of perhaps a half dozen or more papers and articles looking at this basic material for more information about the experience of going off of psychiatric drugs.
Sorry. Thanks, Adele. Over to you, Karen.
Hi, my name is Karen Hoffman, and I am a admin and moderator for a group called Cymbalta Hurts Worse. We are a group that's been around for about 10 years. And really what our mission is to help people taper safely off of Cymbalta. People usually come to us in severe withdrawals, and they're looking for help, and really they're looking for validation of what they're going through and what's happening to them. We have currently about 35,000 members, and on any given day we have, I looked last night, we have between 12 and 15,000 active members on a daily basis. I mean, obviously if it fluctuates. We have people that have joined our group from 100 different countries. We have people in our group that do interpreting for us. So we're just really a very, very busy group. We have about 17 admins and moderators that help out. We take each question that is put in front of our group and it's answered by a moderator. So each person gets individual attention, which could be super time consuming. And we, just try to do the best that we can to give peer support and guidance and help people learn how to advocate for themselves when they're talking with their psychiatrist or their provider, or whoever it is that they're working with to get their prescription.
Thanks, Karen.
Sure.
Sarah, over to you.
Hi there, I'm Sarah Tilley, and I'm involved in a small peer support group in the UK, Worcester Withdrawal Group, which was started in 2019 by two local people, Stuart Bryan and Sue Owen, who both had a lived experience of trying to come off psychiatric drugs, having difficulties, finding that there was absolutely no validation, no support locally. So they put the group together. The meetings ran face-to-face fortnightly, and it was kind of a service just to bring people together so that people could share their experiences of trying to taper and the different symptoms that they're going through. And then the pandemic came along, so due to that we went on to Zoom. So for the last couple of years we've been running weekly Zoom meetings. That has kind of given us the advantage to sort of open it up a little bit more to people across the UK. So
thanks very much. Welcome all of you, and thank you for all of the work that you all do for such a long time. There's so many people. I'd like to kick off with a question to each of you, a very simple question, a very important one. Why do people join your peer support group? And maybe we'll go around the same order again, perhaps. Adele, would you like to go first?
Well, my website is, it's kind of, a lot of people might look at it as being sort of an antique because it's in a forum format. And so people start topics and then everybody can respond to topics. And this is, given how people are using their phones and also are very accustomed to Facebook, it's not the easiest site to use, but people are really desperate and they look and look and look for help. And they come to my site and they join my site because they really want to ask questions. So their motivations are usually that they become very, very confused by what their doctors are telling them. They're not getting good results from whatever drugs they've been on. They might be on combinations of drugs. They might feel terrible. They might be disabled from taking the drugs. And they might also have what are very strange symptoms of protracted withdrawal, and they've been to see doctors and neurologists and endocrinologists and all kinds of specialists, and they can't figure out what's going on. And so at some point they might run across a comment in a social media thread that says something like maybe a protracted withdrawal, and they start Googling that, and then they come to my website. So I would say that people are very, very motivated because they are desperate and they can't find answers anywhere else.
Yeah, that makes sense. Karen, what do
I
you
would
think?
I would piggyback on what Adele said. People come to our Cymbalta Hurts Worse group, which is really just for Cymbalta duloxetine support, although we do have many people that are on many different drugs. And then we often actually refer them to Adele's group because she has I would say the biggest, vastest information for all the antidepressants and some of the anti-seizure medications as well. And I think you're doing a fabulous job, Adele, with as much as what you're handling on your website. But when they come to us on Cymbalta Hurts Worse, they're typically in withdrawals. They can't sleep, they're vomiting, they have diarrhea, they're confused, they have brain fog, they can't hardly formulate a full sentence. And what we try to do is try to help educate them, to let them know that what they're experiencing is withdrawals, and that if it's within a certain time frame, we suggest that they consider going back onto the drug so that they can eventually do a safe taper off of it. And it's quite the undertaking when someone is so confused, to try to get them to understand, how the drug works, how to do a hyperbolic taper. And then the other thing, more recently, what we've been seeing is people are coming to the group, they get a prescription for Cymbalta, they Google it, and all of a sudden our group pops up, and then they come and they ask questions. So then we try to give them as much informed consent as we can from the moderator admin perspective. And then typically what happens is other members of our group will come on and they will like to say, don't take it because of X, Y, and Z, or they will, give their history of what their withdrawals are. So I would say those are the two reasons why people come to our group. We do have some physicians that have joined our group and asked very specific questions. We have a couple researchers that are in the group. We had one, I'm in the United States, and we don't see as much research being done, I don't think, here in the United States as what is being done in Europe. So I commend all the researchers in Europe for everything that you're doing. But we did recently have one researcher from the University of California in San Diego ask some specific questions about duloxetine and information about it. So I thought that was very encouraging that we have more physician information and more physicians are joining the group to learn. We have one pediatrician who was on Cymbalta and now is trying to get off. And he said, I had no idea. He said that these drugs were like this. So it's been, it's really been eye-opening, I think, for everybody, from, the lay people to, the medical people that join our group.
Yeah, I saw someone in the chat just wrote, I learned more watching that last video than 2 years of medical training.
I know, I saw that too. That was wonderful. I'm like, yes, we're getting the word out.
Yeah. Okay, Sarah, over to you.
Yeah, similar, I think, really, to what others have said. I think there's so much despair, confusion. People are left on their own. They're going through something, in some cases pretty horrific. They're not able to work. There's a lot of fear and frustration that they take these problems to their doctor and they're not believed. And it's this sense of, who can I speak to? I think just needing to sit with someone and just have a conversation with somebody that really gets it and really understands. And we have people come along that are at very different stages of their journey. There's people that have just started a taper, people that have stopped and reinstated, people that have slowly tapered, people that are in protracted withdrawal. I think the protracted withdrawal can be quite difficult because people are kind of left on their own and they're suffering and they're struggling months and years later, not really knowing where they can go or who they can talk to because it's so sort of poorly understood. And then some people go on to be diagnosed with other things like chronic fatigue, fibromyalgia, POTS, and I think it can be really frightening for people. So I think to have that space where people can be together and just have a conversation with somebody else that kind of gets it or who has had a similar experience, I think that in itself can be kind of a little bit therapeutic, just to be able to talk to someone, even though we don't have the solution and we don't give out tapering plans or anything like that, but it's just somewhere where hopefully people can feel less alone.
Yeah. Any of you want to come back on that? We'll move on to the next topic. Comment on what your co-panelists have said.
Well, certainly the looking for validation is a really important driver for people coming to these support sites. I mean, I don't think that anybody really wants to be searching the internet for help. I mean, they would really rather have it from their doctors and the people around them. So not getting that, not getting the validation, not getting the emotional support is really it's really devastating to people. And I've had people tell me that they burst out in tears when they, when they're we say, yeah, those are typical symptoms of withdrawal, or when you went off of paroxetine 4 years ago and felt so terrible, that's the start of your protracted withdrawal syndrome. Just knowing what they might be feeling is really very important to them, and their faith in medicine has been shaken. And this is something that you don't really know about until you hit a blind spot in medicine, because I think that we all assume that if we get really sick or something really bad happens, that doctors will be able to help us. We have a lot of trust in them. It's very important to our sense of well-being to know that there's a place to go if something really bad happens. And then here they are, they've suffered this neurological accident and nobody knows what it is. And they get told over and over again that it might be their depression, even though they have weird symptoms that are unrelated to depression, or that they've developed a new psychiatric problem and they need more drugs. They might have had a series of drugs and gotten to feel worse and worse and worse about it. So they're really very frightened, and sometimes very angry, and they want to reject all medical help because of this. But it's important to understand that there are blind spots in medicine, and unfortunately, with so many people taking psychiatric drugs, adverse effects of psychiatric drugs and going off of psychiatric drugs is one of those blind spots.
Yeah, we're just in the process of analysing one of our large surveys, which you people like you make possible. You mentioned research, Karen, so I'm one of those researchers, and it's a good opportunity to thank you all for helping us reach people to fill out these surveys we keep putting out. But one of them is, Stevie and I were just analysing about 1,000 in the last few weeks, and one of the most common things was exactly what you said, Adele, like the number of people who just wanted to be believed. That simple, like the pain of trying to tell someone what's going on, the person who should know most in the world, and not being believed. It was just so painful. So many people write about that in these surveys. Sorry, I'm not supposed to be twittering on.
I do think it's not only are they not believed, but we often see people get their prescriptions pulled, and then they go into major withdrawals. And then we're like, you know what, go to urgent care, go to your pharmacist, go to the emergency room, go wherever you can so you can secure your prescription so you can reinstate and do a slow taper. And to me, that is the most heart-wrenching, as you know, an admin moderator for our group, is when someone comes on and said, oh, my, you know, the lowest dose of duloxetine is 20 milligrams. They've been on 20 milligrams now for months. They're already having problems. And then they say, well, you're done. And then they go into big withdrawals and they can't get a prescription. So one of our big things is that we really try to help them learn how to advocate for themselves. And even honestly, sometimes we tell them, you know what, if your doctor doesn't believe in slow tapering, don't tell them you're tapering. And I know that goes against everything that we all believe in, that you should always be honest, always tell your doctor everything. And we want people to do that. But if they're going to pull their prescription, then you know what, you have to do what you have to do to protect yourself. You have to advocate for yourself. And it's hard for people to do that when they're in such distress. They just want to be heard.
Yeah. I think if I could just add to that as well, I think for me, I think often the real cruelty of this is that it can be such an invisible illness, such an invisible problem. I think people can look well, right, and sound well, and a doctor will say, well, we've done all your bloods and everything's fine. But like Adele says, it's like a neurological injury that people just don't see. And some of those symptoms can be so distressing to try and describe to somebody what you're going through. And the validation is so important. I think that's the first step, you know, just to be able to say, this is what's happening to you. You know, we're sorry that you're having this experience. We know this is a problem. We maybe don't quite have the answer just yet, but, you know, we see you and we hear you and we know what's happening. And unfortunately, that just isn't happening for many people.
Yeah, as Karen said, that it can be even difficult getting your prescription from your doctor because of the doctor's misunderstandings about the process of tapering and withdrawal. And this is also extremely frustrating and just really just causes such emotional upset for people because they don't want to argue with their doctors. They don't want to fight with their doctors. They're afraid what will happen if they contradict the doctor. And so they're kind of, yet they just don't know what to do. It's like, unfortunately, although I have to say here that antidepressants are not technically addictive, they are in the situation of a person who needs to have their drug. You know, they need to find that ongoing prescription somewhere, especially, let's say, with benzodiazepines. There's been the medical community now really condemns benzodiazepines, and people are being cut off without tapering. This is terrible because benzodiazepine withdrawal syndrome has been known for a very long time, but there's just a general ignorance of necessity of gradually going off of these drugs across all of the prescribed psychotropics. So one of the things that we often do is have to tell people how to talk to their doctors. And I want to I want to just take a minute here and say that if you need to get your doctor's help in tapering, you need to be very calm. You need to, don't cry, don't raise your voice, don't show any emotion, because if you do, your doctor might think that you're mentally unstable. And what you need to do is to talk very calmly, very firmly, tell the doctor what you want. Don't ask the doctor what he or she thinks. Tell the doctor what you want and say that you're going to take responsibility for the results. Now, we have people who have been advocating for themselves and still don't get any help from their doctors, and you might have to go to another doctor. In most countries, any doctor can prescribe a psychiatric drug. So if you have a better relationship with your GP than you have with your psychiatrist, there isn't any reason to keep your psychiatrist on your payroll in order to argue with them about tapering if your GP will help you. So you can talk to your, if you've got a good relationship with your GP, you can say, I would like to gradually go off of this drug to see if I've recovered. I'll be very careful about it. Please help me. And you might be able to get a GP to help.
The other thing, just to add to what Adele said, the other thing I think that is helpful is if, people are obviously on the internet, they're doing their research. If they look for evidence-based research and they print those articles out and they take them into their physician and they say, this is what I found. If they have a good relationship, if they don't have a good relationship with their physician, this isn't going to work. But if they do, then it helps educate them. So the next client that they have, the next patient that they have, they will not be, oh, I've never heard of this before. It'll be a repeat thing. So I really do think the evidence-based, because physicians are scientists, it's all about the evidence-based. And there's a lot of information out there now with, Mark Horowitz and Anders Sorensen. And I mean, there's tons. John, you have a ton of information out there. There's so much, but I just don't think like a general practitioner, internal medicine, those people don't really have time to do any research. I don't think they don't care. I just think they don't know. If they knew better, they do better. But they don't know about it. So, it's really up to, I guess, us to teach them.
Right. And if you very calmly and firmly talk to them, they need to go on to the next patient.
Right.
They'll just say, okay, I believe, hopefully they'll say, okay, I believe you, and give you what you want. Tell them the prescription that you want. If your doctor says there's no such thing as a liquid for your drug, be sure that you go with some printout of something from the web showing that this drug is available in a liquid, and there's an ordering code, and show them the code. So you have to guide them along, but you're going to be working with them cooperatively. Don't be begging for their help, because it just confuses them.
Mm-hmm.
Kind of a bit backwards, isn't it, when the patient has to educate the doctor? But and that kind of leads us into the other question we said we would spend some time talking about, which is which is the title of the session. How can peer support change healthcare? Perhaps we'll start at the other end this time. Start with Sarah, if that's all right.
I think trying to involve people with lived experience as much as possible in research, people that are maybe thinking about setting up services, it's so important to listen to people, to believe them, and to just try and take on board that lived experience, because there's so much happening that kind of isn't always in the literature that people get confused about. And I think really listening to people and seeing what they've been through kind of gives an accurate picture of what can happen and how people cope or don't cope. I was involved with a couple of other people just last year with Bath University. They were doing a project with some third-year pharmacy students about the availability of liquid SSRIs. So a few of us were involved in that, just talking to students. I just found that so encouraging that they were kind of looking to people that, had used liquid versions and tapered, And I think sort of going forward, it can be really impactful to be able to draw on people's lived experience. I think the issue with protracted withdrawal is so difficult. I think that's something that healthcare really needs to pick up on. It's, you know, being able to identify that a problem you're having a year or 2 years after coming off a drug can still be related. And I'm not quite sure yet how we do that. But there's so many examples there of people who have been told. I think Mark touched on this earlier, that, you know, it can't possibly be the drug because it's out of your system. You've been off it so long. And I feel we've got a real gap there in terms of picking that up, recognizing what's going on. It does leave people kind of vulnerable to being diagnosed with other things and put on other medications. So I think, and also I appreciate doctors are very busy and the health service here is in crisis, but I think that, you know, if we can find a sense of curiosity and intrigue about what people are saying, which again, unfortunately, that doesn't always happen. But yeah, I think listening to people and hopefully drawing on people's experience within services.
And hopefully having them paid to do that when they do that. The people do it out of the kindness of their heart, but I feel quite strongly people should be paid for that work. Karen?
You know what, I really think the most important thing as far as the peer support, how it can change healthcare, is physicians try to talk to your physicians. And actually, I know there's a lot of physicians, a lot of providers that are listening right now. And I think the way to change healthcare is when a patient, a client comes in, that the provider listens. They ask questions, they listen some more, they validate what the person is saying, and then they listen some more. Because the only way it's going to change in our healthcare system, and I don't care what country you're in, is if the physicians really listen, because nobody wants to go and be in withdrawals. They're not making this stuff up. These aren't fake symptoms. They're real symptoms. And because you can do all the tests, you can do all the CAT scans, all the MRIs, all the blood studies, and everything comes out negative. Because there's not a test to do to see if you're in withdrawals, you have to listen to the patient.
Yeah, I would certainly hope that's so that I think that one of the things that peer support, being open on social media and on the web, can do is to encourage people to talk to their doctors in more of a collaborative way. I think that we're maybe emerging from a culture where everyone had put their doctors on a pedestal, and they're looking for like top-down direction from the doctor, and there's a hierarchy where the patient doesn't question what the doctor has to say. And I think that what getting people together to talk about these problems that are not really well recognized by the medical community is it empowers people to talk to their doctors in a clearer way and educate their doctors. So I think that our groups are actually gathering places where people can be empowered, and also that we can join together in an activism that really can help change psychiatric prescribing. And I think that that's really important, that this is an unusual situation in medicine, because the information is coming from the grassroots. The information is coming from the patients. And this really, again, it's, we're in I think a transitional period in, I guess, the culture of medicine, where the patients really need to be able to be included in medical policy making and understanding conditions. And this is emerging in the ME/CFS community and in long COVID and in other chronic diseases that are somewhat
12
mysterious
o'clock.
is that the patient is going to, the patients are helping to educate the doctors.
Mhm.
Anybody want to add anything before we go to questions from the audience?
Just that I was just thinking there, listening to Adele say about long COVID, that not to bash long COVID in any way, but there is a lot of overlap, I think, in long COVID and withdrawal syndromes, and there's a lot of interest in long COVID. There's clinics, you know, there's places people can go, and it's just such a shame that we don't have that in withdrawal. We just don't have that level of awareness or concern. It would be lovely if we did.
Well, there's such a strong belief in the medical community that problems with the psychiatric drugs are extremely minor and they don't really need specific attention. And again, this is something that patients can communicate, that so many people are on so many drugs that this is called the iatrogenic problem, needs a lot more attention, because medical prescribing is creating maybe a public health issue on its own.
I would agree, and I really think the medical society, especially in the US, needs to start more. I don't know of one, and there might be, but I don't know of one deprescribing clinic in the US, and it would be so helpful.
Yeah.
Okay, thank you all for all of that. I'm gonna move to questions from the audience. There's a lot of some good ones here. I'm going to start with someone from Brazil, Letitia. I've created a WhatsApp peer support group here in Brazil. We are now 15 women, and none of us could taper off completely from the drugs. The only thing I feel I can do for them is to validate their experiences and offer qualified information, which I bring from surviving antidepressants and in the Compass Withdrawal Project. But it's been very hard. Some of them are completely disabled, and I feel sometimes very impotent. What can I do to be a better facilitator?
That's a really good question. I think being there and just holding that space, the fact that you're there just to listen, I think that can go a long way. You know, it's about listening, being there. I'm sure people really appreciate that, but it's very tricky when people are really suffering, because you naturally want to give a solution. So I feel for that lady, but I think the fact that you set something up is a massive step, and you know, just being there is making a difference.
Yeah.
Yeah, it is very distressing for people that, like in our group, Adele's group, Sarah, in your group, when you have people that are in protracted withdrawals that are coming, and it's just one thing after another. They can't get out of bed. I mean, these people can be like this for months. But what we've seen, and I'm only speaking for our group, is we've seen that if people are holding at their current dose, or if they've gone off cold turkey, we try to tell them that it's a temporary situation. It's going to get better. We don't know how long it's going to be. We don't put rose color glasses on anything. You know, we tell them it could be months, it could be a year, it could be more than a year. We don't know, but typically, not always, but typically, people do get better. And it's just the essence of time that heals, because there isn't a magic pill people can take. There's not a magic supplement people can take, and everybody's looking for it, but there isn't one out there. It's just really, you know, the time and the healing of the, you know, the receptors, so that your brain can heal.
Yeah, this is really, really hard, because there's so many things that could be influencing this difficulty in going off of the drugs. I just want to give one tip though, and that is that if you're tapering and you run into withdrawal symptoms, stop tapering, because if you continue to reduce, your withdrawal symptoms will probably get worse. And what we've seen is that if people just, you know, just stop tapering, that, and hold at one dose for a while. I mean, it could be 6 months, it could be
A year.
it could be a year, it could be 3 months. If they just hold that one dose, that generally things settle down. Now, sometimes you might have to go back a little bit and increase the dose a little bit to get back to like the platform where you used to, before you got withdrawal symptoms. So when people get withdrawal symptoms while they're tapering, they often misunderstand and just want to get off the drugs right away, and they just keep tapering. And no, you need to be patient.
Yeah.
So it could be that if everyone has been determined to taper in that group, that they might just need to wait a little bit and let their systems recover from the changes that they've been making so far.
Yeah, you can't, I guess I would say you can't push through if her people in her group are trying to push through the taper, it doesn't work. You have to hold at your current dose, or like Adele said, maybe go back up a touch until you feel more stable. And then once you do feel stable, wait for a bit before you try to resume your taper.
Yeah.
Okay, the next question is a specific question about antipsychotics or neuroleptics, and it's about how do you cope with situations when people are constrained by force or coercion to take antipsychotics. But I want to sort of broaden that a bit, if I may, because we talk, as is often the case so far, we've talked a lot about antidepressants, a bit about benzodiazepines, and not very much about antipsychotics in general. So can I ask a sort of more general, because how many of the folk on your Facebook groups are dealing with antipsychotic withdrawal, and how do you help them? And then we'll come on to the specific question about when they're under the Mental Health Act.
Well, I'm going to defer to Adele because we really primarily just deal with fluoxetine.
Same.
Okay. In the United States, antipsychotics are being prescribed for reasons other than psychosis. And they're being prescribed for sleep. They're being prescribed in the misunderstanding that they're calming drugs that are safer than benzodiazepines. They're being prescribed as antidepressants. So we have quite a few people on my website that are tapering antipsychotics who don't have a history of psychosis. We have fewer people who have a history of psychosis who are tapering as well, and some of them are tapering from depot injections. One of the problems with the antipsychotics is that because of the action of the drug, if you taper too fast, you can get symptoms of psychosis even if you've never had any prior experience with psychosis. You might get those symptoms if you're taking quetiapine for sleep. So it's important to taper carefully when you're going off of antipsychotics. And if you have a history of psychosis, this goes double, because if you end up going to the hospital or your doctor, it's most likely they're going to increase your dosage quite a bit and maybe add more drugs because they don't want you to have psychosis. Another symptom that might come from tapering an antipsychotic is movement disorder. So it's important, again, to very carefully taper to avoid these symptoms. This can be hard for people because sometimes the side effects are so unpleasant that they just want to get off the drug as soon as possible. But as the dosage goes down, usually the adverse effects will diminish. So you can look forward to that. Now, if you're on a depot injection, the depot injection will wear off over a certain period of time. They're timed so that you take them you have to get the injection every month or 6 weeks or whatever. It depends on the drug. And so it tends to wear off. Now, so you could say that it's, your body is tapering it as it wears off. However, some people find that when they get towards the end of that period, when the injection is wearing off, they start to have withdrawal symptoms. And those withdrawal symptoms can be all the strange symptoms that you can see from antidepressant tapering, or it can be, again, symptoms of psychosis or movement disorder. And that means that if you want to taper off of your depot injection, that there are a couple of ways to do it. One is to get a cooperative prescriber to give you lower doses of injection every time you get an injection, and then at the end to supplement with some a liquid, very small dose of a liquid or a fraction of a tablet in order to taper off using a liquid or a tablet. This is pretty complicated, so I'm not going to go into detail here. But again, it's very, very important to taper off of an antipsychotic very carefully. Do not continue to taper if you get withdrawal symptoms, and watch out for these warning signs that can be taken as symptoms of psychosis that'll get you remedicated to the gills.
Yeah, it's fairly uncommon for people taking antidepressants to be forced to take them legally, but it's very, very common, as you know, for people to be forced to take antipsychotics legally, which is an interesting human rights issue. But do you have any thoughts on that? Do you have any folk on your website, Adele, who are dealing with that issue and ask you what to do in that situation?
Well, that's really hard because you have to get the cooperation of your doctors to modify the conditions of your whatever order you're under. So people have to negotiate with their doctors. There's just really no way out of it because you need to get a doctor to sign off on your new plan. Yeah, again, that requires calmly and very firmly presenting your case to the doctor. If you've been, for instance, having adverse effects from your antipsychotic for X number of months or years, you might ask the doctor to minimize the dose to the lowest effective dose rather than ask to go off completely, because that will really upset them. So if you're under a court order, then you can again negotiate with your doctors to reduce your dose to the lowest effective dose. Again, you need to do this very, very carefully, because if you start to show even ordinary withdrawal symptoms during this process, not symptoms of psychosis, they'll take it that you really need to have that upper, the higher level of the drug just to, they don't want you to become psychotic again. So they're really afraid of that. And they tend to, they prefer to err on the side of higher dosage rather than lower dosage.
Indeed, she's treating their anxiety, I think, rather than anybody else's.
Good point.
Let's move on. Now, Sarah has sort of addressed this somewhat already, but it's a question from Hillary. Tapering support is crucial, but how do people get support if they have stopped their drugs suddenly or who have been taken off suddenly because of adverse reactions? They tend to get left to cope with this on their own, and the symptoms can be very severe. It's an extremely alarming situation for the patient and their family. We need someone with expert knowledge who can monitor the situation throughout, even when there is no longer a drug involved. There's several issues in there, I know, but
that's a really great question. And that is a real issue. We've certainly had people within the group that have been taken off numerous drugs abruptly, and they're now into an acute withdrawal. It is very challenging. It's difficult sort of knowing where to kind of signpost people to kind of get the best support. I think some of the things Adele touched on in speaking with your doctor can be helpful, but there's still people trying to advocate for themselves and running into difficulty. I think sometimes possibly it can be helpful to have somebody with you if you try to explain and talk through some of these things. But I think for our group, I feel a bit useless kind of saying this, but we just really try to sort of listen to that person's experience. And I guess that's one of the limitations of our group, is we can't really do much more in terms of, you know, telling people sort of where to go and how best to deal with it. I think it's really hard when people are trying to seek advice and, you know, being offered more medications. And you know, we do see this sometimes, and I'm always unsure what to say, really.
Yeah, I don't really know that there are any answers or anything in particular that you can do, or a provider can do, a medical provider can do to help somebody in protracted withdrawals. But what we advise on our group is really work on a clean diet, you know, cut the carbs, drink lots of water. I mean, some people can't because they're so nauseated. If they get super dehydrated, they're going to have to go into a healthcare facility. And we've had that happen on more than one occasion. You know, I think you just have to kind of support the person and support the symptoms, and just wait for the essence of time to pass, you know, to let your brain heal, let the receptors heal. And it's very distressing. And I just think validating over and over again, you know, that what they're going through is real, and their symptoms are real, and there's a real reason why it's happening, and that, you know, it's hopefully a temporary situation, and it's going to improve, and give them hope.
Right. Yeah, there really is no place for people with protracted withdrawal to go except, yeah, our groups. And this is very difficult because often people have been suffering for such a long time, and there really aren't any easy answers. Sometimes people find that taking additional drugs, their doctors will try to help them by prescribing other drugs to them, it makes them worse. This is a condition that really needs to have more investigation. I co-authored a paper with Michael Hentgartner on protracted withdrawal from antidepressants, based on a fairly random selection of patients from my website. And there were 69 people involved. And it appears though that kind of the recovery from protracted withdrawal, if you don't do anything to interrupt it, takes about 2 or 3 years. So that's the natural arc of recovery from protracted withdrawal. If you've very recently gone off your drug cold turkey, reinstating a partial dose might help you. And I have to say here that unless you really need to, it's not a good idea to cold turkey a psychiatric drug, because you are really going to put yourself at risk for severe protracted withdrawal. But there are just so many issues in protracted withdrawal. It's very hard to generalize about them. But in general, we do see extremely gradual recovery over years.
Okay, moving on to the next question from Michael or Mikhail. How important is it that the support person managing the groups has gone through the journey of getting off antidepressants themselves?
I think it's very important. I honestly don't know how you could, well, I shouldn't say that. We expect physicians to, and they haven't gone through it. But I do think that the peer support groups, that people that have gone off and have experienced different levels of withdrawals, are more understanding and more compassionate and more caring about the members because they've experienced it. I mean, otherwise, like our group and Adele's group, it's all volunteer people. Why would we spend so much time volunteering if we're not trying to help these people understand that, you know, there is light at the end of the tunnel? And you know, you can get through this. It just takes a long time.
So can we reasonably expect doctors who haven't been through it to provide the support that is needed? Bearing in mind that, of course, a lot will have gone through it, but they're not necessarily talking about.
Right.
Let's assume most haven't. Is it fair of us to expect them to provide that support if they don't know what it's like?
That's a good question.
Yeah.
Well, the process of tapering is certainly something they can learn. And the hope is, our expectation is that if people are tapered properly, there's not going to be so much, protracted withdrawal or withdrawal while tapering. It's the bad tapering or the abrupt discontinuation that causes these these problems. So the concept of tapering is, I think, very slowly filtering into medical practice, thanks mostly to the activity in the UK. The people in the UK have been doing a tremendous amount of work getting this into medical guidance, but it's been a very, very gradual process, and probably a lot of doctors who were trained 10 years ago really don't get it. So however, among the people who are researching with tapering and withdrawal, there are quite a few doctors who have gone through withdrawal themselves, who have experienced withdrawal symptoms themselves and been very, very shocked about that. I think you heard earlier from Mark Horowitz. I guess, one of the benefits of all of this, very widespread excessive prescribing is that there's a population of doctors who have experienced withdrawal. So we hope that they will learn how to taper, and they can definitely do that because it's basically math and then listening to patients. I think I should say here that, I probably should have mentioned it earlier when I introduced myself. I'm involved in a tapering, an online tapering service, a telemedicine service in Canada that is offering gradual tapering, and we are training doctors to do it. So again, hopefully the tapering will forestall these very difficult withdrawal problems.
Sarah, did you want to come in on that?
Just to say that my feeling is that, any support is better than none. So even if it's coming from somebody that hasn't been through it, that would be better than nothing at all. It would be amazing and, preferable if you're working with people that really have been through it. But I think any support really from any doctor, regardless of whether they've been through it, would be helpful, be a good thing.
Yeah, I think it's reasonable to expect doctors to have the knowledge that they ought to have, and to be able to share that and to be able to validate whether they've been through it themselves or not. But that last bit of discussion kind of leads me to a question I'd like to ask, if I may. Do you see a point when, in the future, when we finally have got all these doctors trained and knowledgeable and able to give basic validation and help people make an individualized plan and go slowly in hyperbolic tapering and all of that, do you see a point in the future where Facebook groups like yours would not be necessary?
I can only hope that that's going to be soon. I'd like nothing more to blow up our Facebook page and make it go away, but I don't see it happening anytime soon.
But if we did get to that point, do you think there would still be a role for perhaps the emotional support side of things that doctors don't have time or sometimes capacity to provide?
Absolutely. I do think even when people taper slowly, which I actually am still tapering, and I'm tapering very slowly, I do think the peer support is great. I do think people need to go to a place to communicate with other people that are going through the same thing. We do, when people are really in distress or in protracted withdrawals, we do refer them to the Inner Compass Exchange, which is, a newer program now where people can interact with one another that are either, going through protracted withdrawals or are currently tapering or are completely tapered and are still recovering. And I think that's a great format for people to look into. It's just, I just can't say enough about it.
Yeah, Lucy, maybe you could put the Inner Compass link website up again for people. I know you already did that. Thanks. Yeah. Adele, Sarah, what do you think about this? Is there a utopian point in the future where doctors are doing their proper job in terms of providing information, but the emotional support still comes from peer support?
Yeah, I think I agree with Karen. I think there will still be a need for it for some time to come. This is probably maybe a tricky aspect of withdrawal, but I think you can end up with issues where people come off drugs and there's this identity crisis of who am I now? This feeling of being lost or disjointed or not quite knowing who we are. There's these strange things that can come, I think, with being on treatment and coming off. And these are things that they feel quite profound and quite complex. And it's very difficult to find a place where you can kind of talk to other people about those things. And I still find it hard to imagine the healthcare system or a doctor being able to pick up on those things. So I think the forums are great for that. Talking to people who've been through the same thing. So my feeling is that even if we progress, there will still be a need for a space to kind of talk about some of those things.
Yeah.
Again, I think that I'm hoping that we're in a transitional period and that ultimately people won't need peer support for guidance about tapering. They'll be able to get that from their doctors. I think that currently there's an enormous wealth of knowledge about tapering and withdrawal in peer support. So this, I'm hoping that this would get translated to the general medical community. Social media being what it is, I expect people to get together when they have similar problems. So I think that there'll be ongoing peer support in an informal sense, as long as people can identify each other and connect through different kinds of platforms. There's a handful of ventures, I guess you could say, that are offering tapering. In the United States, there are a few businesses started by psychiatrists where they offer the full range of mental health services, including tapering and also psychotherapy. And I believe that they are tending to add forums to their services so that people can provide peer support to each other. So it's perceived as it's something that comes out of social media, that people are going to talk with each other about their problems, and so it's probably going to be some kind of ongoing component.
Okay. Well, that's brought us nearly to the end. Thank you, everybody, for your questions. I'm sorry we didn't get to all of them. I'd just like to ask each of the panel members to take one minute for their closing remarks, words of wisdom, or whatever they'd like to share with us all before we leave. We'll start with Sarah.
Just that I think being involved with peer work and having sort of gone through this myself, it makes you realize just how severe this problem can be. And I think even amongst people in healthcare that do recognize withdrawal, there's a sense that we're not understanding or we're not appreciating just how severe this can be for people, with people unable to work, people not able to do the things that they were able to do before withdrawal. So it still feels like a really difficult situation. And I think that we need better support. I think we need a proper helpline, maybe a 24-hour helpline and proper services, and for people to actually be able to go and physically sit down and see someone face to face. I think that would be great. But in the meantime, you know, the peer groups are important.
Thank you. Karen.
I think the biggest thing that I would like people to understand is that when you're tapering, go slow. Even if you're not a science person, try to understand the science behind it, because once you understand the science behind tapering, it just makes more sense to go slow. You can live your life, you can go to work, you can do all your family events, you can travel, you can do everything and continue to taper your medication without letting it disrupt your life. If you go faster, you try to push through it, you're more than likely going to go into withdrawals. So just go slow. And if it takes you a long time, so be it. At least you're healthy while you're doing it, and you're not doing more damage to yourself.
Thanks, Karen. Last words with you, Adele.
That's such good advice, Karen. Let's just, you know, stop this at where it starts, which is bad tapering. I would say my goal is to really transfer this responsibility to doctors, and so I've put a lot of effort into doing what I can to educate doctors, including asking my group members to tell their doctors about their problems in tapering or going off of their drugs. So I would like to suggest that that if we can get this going, that people talk more frankly with their doctors, that this would be a tremendous contribution of peer support to improving medical practice.
Thanks, Adele. And thanks to all of you again for a wonderful hour, but thank you especially for all the work, as I said before, all the work that you've done for so many people. It goes unseen, but we see you, and we thank you and we love you. Thank you for all that you do. In a quarter of an hour, we're inviting all of you to come back for a broader discussion where everybody can try and get their 2 penny worth in for an hour, and you can show your face if you want, and it'll be much less controlled by people like me telling you how much time you've got to speak and everything. So come at a quarter to the hour at 6:45 in Britain, but basically 15 minutes from now, and Ruth and Stevie will be facilitating that, and there's a different link to that meeting. It's in the chat now, so I hope to see you all, or as many of you who can make it, in 15 minutes time. Thanks again to Sarah, Karen and Adele. Thank you very much.
Thanks, Scott.